All right, I know we have a lot to go through today, so we'll get started and we'll just continue to allow people in as they trickle in. So hi, my name's Candida Williams. I'm a master's student in the Department of Family Medicine, and I will be the moderator of today's seminar. Before we move on, I just would like to acknowledge the lands that we are working and studying on. So McGill University is located on land which has long served as a site of meeting and exchange among Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters in which we meet today. Next, I will present each of the speakers that will be presenting today. First, Dr. Jeannie Haggerty is a full professor in the Department of Family Medicine and the co-director of the McGill Primary Care Practice-Based Research Network. She holds the first McGill Chair in Family and Community Medicine Research based at the St. Mary's Hospital Center. Her domain of research is the factors related to accessibility and quality of primary care, particularly the impact of health system policy and reforms. Next, Dr. Peter Nugus is an associate professor in the Department of Family Medicine and the Institute of Health Sciences Education, as well as the co-director of the McGill University Practice-Based Research Network. Drawing on a background in political science, philosophy, adult education, and sociology, he has published ethnographic and participatory research in emergency departments and various hospital and community settings across 6 countries. Third, Dr. Alayne Adams is an associate professor and population and global health director in the Department of Family Medicine. She is an applied social scientist with expertise in urban health and nutrition, health systems research, and the social determinants of health in Africa and South Asia. Her research investigates the complexities underlying inequities in health and healthcare and innovates community-based solutions both locally and globally. Fourth, Dr. Nadjib Mokraoui is the coordinator and facilitator of the McGill Practice-Based Research Network since 2017. He is a general practitioner and completed a master's degree in clinical sciences at the University of Sherbrooke under the supervision of Dr. Jeannie Haggerty. His research interests are diverse, but mainly focuses on the epidemiology of chronic diseases and multimorbidity. Finally, Dr. Kimberly Munro is a family physician and clinical supervisor at the GMFU Village Santé in Parc Extension. Next, I'll just like to remind everyone of the subject of today's seminar, which is titled Telemedicine During and Beyond the COVID-19 Pandemic, Transferable Lessons from the Experiences of Primary Care Clinicians and Patients. Finally, I'm just going to remind everybody of the process of today's seminar. All the presenters will speak first, and we will leave around 15 minutes at the end for a Q&A period. So please feel free to leave any questions in the chat, which we will address at the end, or you may post them at the end or raise your hand at the end, and I will call on you to speak aloud. This seminar is recorded, as you can see, so if you will not like to be in the recording, please feel free to keep your videos off. With no further ado, whenever you're ready, Jeannie, feel free to share your screen.
Actually, I don't have a screen to share. I just wanted to give you a very brief introduction. Today is the seminar for the Practice-Based Research Network, as Candida said. So we just wanted to give you a little bit of background on the network. And then I'm going to just provide the context for the 2 studies that we're presenting today. So first of all, the mission of the McGill Primary Care Practice-Based Research Network is to produce and apply research knowledge from and for clinical practice in partnership with clinicians, researchers, and patient partners with the ultimate goal of improving patient care. And we try to do that by really connecting the strengths in our department in the research strengths with the strength of clinical practice through networking our 9 teaching units in the department as well, and we're beginning to associate more private clinics now. We are trying to maintain an activity of, there's various practice-based research going on, and practice-based research going on. And today we're going to be presenting 2 of them, but we're really trying to promote that sort of practice relevant research, not just in the topics, but also in how research is conducted. And so we hope that today will be an illustration of that. given that most of the audience today are also students, I wanted to tell you about a program that we have called Practice PBRN Fellows. And this is a small award that is available for PhD students who would be interested in actually working alongside either a clinician who is interested in an area that's relevant to them, or actually trying to be embedded in a clinical practice as being a research presence there. So we hope that we'll be issuing a call for that soon, and please keep your ears open. So just to provide the context for this, for the studies that we're presenting today, these actually were both born at the beginning of the pandemic, which is hard to believe. It's 20 months ago. And at the beginning of the pandemic, as you know, there was a couple of things that happened. First of all research activity ground to a halt, that we could no longer do a lot of our field work. And there was, and then the other thing that happened was that in clinical practice, there was an almost immediate use of care by virtual visits called telemedicine. That's what we're referring to it today. And in fact, none of the literature that was around that pertained to uptake of telemedicine and digital modalities pertained in this situation, because it was like an overnight transfer. So the Réseau One, which is the supporter that supports us and is the primary care knowledge network for Quebec, they actually pivoted very quickly and funded a project just to see what was happening across Quebec in terms of uptake and use of telemedicine. And there was a survey that was done, and then Peter Nugus did some focus groups, which he's going to present today, looking at clinicians and how they actually used telemedicine, how they intend to use it in the future. At the same time, one of our family physicians came to us and said, none of my usual patients are showing up at my clinics in telemedicine, and I'm just worried about them. Maybe they can't use telemedicine, what's happening? So we were able to also pivot relatively quickly, as researchers go, and slow for everybody else in the whole world. We were able to pivot rapidly and actually put together a study that explored specifically among high need patients some of the difficulties and challenges that they had with telemedicine. So that's the context for what we're presenting today. And it's interesting in that it really feels to us that as being, we learned a lot from doing these practice relevant pieces of research, which we'd also like to share with you today. And we're lucky to have one of our clinicians with us today. And she will be presenting and reflecting from her perspective on these two studies. So over to you, Peter.
Thanks very much, Jeannie. Can everybody see my screen?
Yeah.
Okay. As Jeannie mentioned, I'm going to present the results and some lessons from one of the two studies Jeannie referred to. Mylène Arsenault was also involved in this, and so Mylène can't make it today, unfortunately, but she's been a big inspiration behind this work, and so I'll present on our behalf, and I'm going to fly through fairly quickly because we've got a lot of parts in this presentation and we want to save time for questions at the end, and people could individually ask me if they want to see the slides. We're going to look, obviously, to be distributing and publishing this as soon as we can. Okay, so these are our partners who've been introduced already. So basically, what I'm going to present is very briefly our rationale, the methods, the findings, and some of the lessons that we learned about clinician researcher engagement. So speaking of lessons, I didn't intend to separate all the points out, but here we go. So basically, the rationale for the study has been, from a research point of view, has been the fact that Canada and Quebec in particular have a very low uptake of telemedicine compared to other Commonwealth countries. In fact, at a rate of about 1/3 of the average of other Commonwealth countries. Even though Mylène Arsenault produced a lovely guide for clinicians at the Herzl and also, more broadly available to clinicians in Quebec, the aims of the study were seen to derive from the lack of empirical guidance about particular clinical and also organizational and circumstantial conditions which should support telemedicine. So the aims are of this study were to understand the perceptions of primary healthcare professionals in using telemedicine and their effects, and also to make recommendations for future use. And as Jeannie said, this is a part of an even broader study, a mixed method study, which also saw a very high participation rate of quantitative surveys, which were directed by Mylène Breton at University of Sherbrooke with 750 participants. So we'll be putting all those together. We did 8 focus groups for this qualitative component, 2 from each of McGill, University of Montreal, Sherbrooke and Laval, the other PBRN sites or university systems, and also 4 focus groups of physicians and 4 of nurses and allied health, so evenly split up among those systems. So I'm going to just briefly go through a couple of broad patterns we found, some positive aspects, some concerns, some conditions of appropriate or inappropriate use that either came directly or were distilled by us, and some impacts on resident education and evaluation, and a couple of points on implications for future use, which came out as data. So in terms of some broad patterns, physicians place more emphasis on telephone use for convenience than did nurses and allied health clinicians. They seem to appear to have been more under the pump from a time point of view. And look, I don't have 3 minutes to, for the patient to sort out their internet. So I suggest we get on the phone and let's start talking. So there was more telephone use, and that was also reflected in the survey as well. An interesting contrast was that nurses and allied health seemed to find that it improved their work-life balance, whereas physicians actually saw that a risk of burnout, which might be linked to the primary decision-making role of physicians. It certainly would be linked to remuneration, which I'll mention briefly in a second. But I suspect that on that point, we can't really necessarily generalize, from that, because it only came from a couple of people from each occupational group. A very, very distinctive pattern was that the quality of IT infrastructure and support at a particular clinic really was quite a governing variable in terms of people's satisfaction, with using telemedicine, and that might not surprise you. All participants were generally supportive, assuming the circumstances were appropriate, and all were fairly optimistic, which could be a sample bias in terms of that it would become easier once it had been used a few times. So some of the positive aspects, video was preferred if it was to be used. Email was appreciated, but a problem was perceived to be that it encouraged a lot more dialogue than clinicians had time for, and that physicians were remunerated for. So it was appropriate only for very brief exchanges of concrete information and document display. Time was saved by not having to travel, and also, as some physicians said, because they could write at the same time, write their notes at the same time, and that patients couldn't see them. So there was a kind of a perceptual aspect of that, even though they felt they could still do both quite adequately. Phone conversations could be augmented by having patients send a picture. That's what physicians said, even though, when we asked, would video have been better? Well, yes, but it was difficult to use. I would have lost 10 minutes, but I sometimes asked them to, send a picture on their phone. Videos also seem to provide evidence of patients' home environment, which could be an advantage. It was good for group teaching, when that was needed. Sometimes enabled multidisciplinary appointments more efficiently to be there at the same time. Obviously, there's an advantage for high-risk patients. Please avoid the clinic physically because you might catch COVID-19. There was a perception there were fewer no-shows, and also healthcare professionals across the board were saying that they improved their assessment and listening skills. So in terms of some of the concerns, there were more concerns than positive comments, but let's see. Some physicians were concerned about the inadequacy of the phone or video for diagnosis in the absence of physical examination. This was more an issue for physicians, having obviously a more diagnostic role. No surprises in terms of looking at technological challenges, poor facilities or lack of facilities or unstable internet from the, the clinical side, but also from the patient side. Clinicians felt untrained, even on what account or what platform to use. And physicians felt, very concerned about what we might call boundary breaches between, private and professional life, and being overwhelmed by patients emailing them. And this was conveyed less strongly by allied health and clinicians and nursing, perhaps because of the diagnostic and the team leadership role of physicians. Other concerns relating to that in terms of physicians and the boundaries were that some physicians felt that the clinic didn't respect their work-life boundary. Emailing created more quick questions, and I just want to ask one more question. And as we know, physicians aren't remunerated for those activities. Also, there was a sense that there was like a boundary change between what was a full consultation and a follow-up, now that they were all by telemedicine, and physicians perceived that patients didn't know the difference and often thought, oh, well, they're ringing me up again, so I can ask a number of other questions and follow up, and, they'll be okay with that. Also, physicians felt that patients were frustrated when they say, okay, I've just told you about it. Don't you think I've got such and such? And the physician would say, look, I really would rather see you. During the summer, when everything was open and just easing into the third wave, some clinics experienced what one person called a délestage, like a kind of a shedding or a cleansing where it was a bit quieter. But the downside was that they thought that there were fewer patients because patients might be nervous about coming in, okay? And also, in some cases, clinics, often more regional clinics, were not yet fully equipped for easy and rapid video conferencing. So this led to wasteful duplicate appointments. Another concern was that older and otherwise vulnerable patients were believed to be disproportionately affected, exacerbating their disadvantage. Threat to the privacy and confidentiality of patients in abusive situations or experiencing domestic violence. The concern that patients didn't respect confidentiality, like, my husband or my wife is here, or sort of professionalism. Yeah, it's okay, I'm in the car, or I'm just in the depot, just excuse me a second. Some physicians said that it was also hard not to succumb to the temptation to check their own text messages when they thought they could handle both. Physician remuneration could be the most significant impediment to effective use of telemedicine. As we know, RAMQ doesn't reimburse for subsequent check-ins, only for what's defined as a consultation. As I said earlier, the boundary became blurred, and physicians are not reimbursed for the time taken to work out how to upload documents, and actually to do the sending of documents and any emailing or communication between what are defined as full consultations. So when should telemedicine be used, or when should it not be used? Well, no surprises that it's difficult to specify that it must be done on a case-by-case basis. Generally, you hear the word generally a fair bit now, generally appropriate for routine or follow-up care. Inappropriate if physical or visible cues or signs are required for diagnosis. Generally not the first time, because it impedes the ability for a physician and a patient to build up a therapeutic alliance and to get important foundational information. Generally not if it's an aggravation of a chronic condition, which would really be a new problem. Rarely appropriate for mental health cases. And it was seen that it might suit patients who are kind of camera shy. Obviously they would be wanting to use it by phone, or who wish not to have their condition visible for whatever reason. Generally not appropriate if a particular tool or material would help with diagnosis. So if it's a physical tool, that with which the physician needs to touch the body of the patient, obviously, that would be unhelpful. But also the benefit of having two screens, like, good practice in telemedicine for seeing the patient and also for taking notes. may not be appropriate for suicidal ideation, not feasible, obviously, if patients lack facilities or reliable internet, and may not be appropriate in violent or abusive environments, even if the particular issue doesn't specifically relate to their, to the violence or the abuse that they're experiencing, and it may not be appropriate for patients with limited French or English or those with limited hearing ability. So impacts on resident education supervision. One benefit was it was taken seriously, like it was actually formalized. Mylène Arsenault, as I mentioned, made a new guide. It was treated as a new teaching topic. It required more autonomy of residents, which sometimes was a good thing and sometimes may not have been a good thing. Because it's inevitable, as we know, it's compelled healthcare professionals and clinics to adapt to its inevitability and to make adjustments. Sadly, some physicians were dissuaded from taking residents at all. Physicians were concerned that residents were not getting a comprehensive exposure to the clinical problems encountered. Given that some patients might not want to come in if they can't be seen in person. And physicians were concerned about residents not gaining sufficient physical examination skills, all of which might contribute to the impression that family medicine is not as fun as other specialties. So some residents would benefit from in-person experience before telemedicine, to understand what the touch of the patient is like for different conditions. Obviously, a physician is unable to see the body language of a resident on the phone, if they're even able to witness the consultation at all, given that sometimes it was done from the resident's home. And it's difficult to find time just to give feedback on what we might call corridor conversations, or I think some people call them water fountain conversations or whatever, when you're just walking through the clinic, to give some feedback. So it was more difficult to find opportunities for that. Implications for future use. Obviously, appropriate IT infrastructure is needed, and some of it's quite basic, really. Basic training, how to use Zoom, support staff for assistance. What was also mentioned was pharmaceutical supplies, other materials that were delayed and took a long time to come and get set up and to get organised, and that was pointed out by pharmacists. A portal that is uniform across services and it's easy to use, and an integrated electronic medical record system, easier said than done. Secretarial support, a nurse to triage, whether it should be telemedicine or not. And the patient should come to the clinic, obviously, if there's sufficient doubts about the ability to diagnose. So lessons that I learned in a nutshell. The first one was it was difficult to integrate kind of two teams. I mean, Mylène Breton was running the quant side. It's meant to be a mixed method study, not two different studies, and so it was difficult across two systems. We were under time pressure, so we didn't get a lot of time to talk about what we were finding at each stage. So there's a problem of integration of methods there that is not insurmountable, and it's certainly not too late. And also in terms of the engagement with Mylène and other clinicians, I mean, that it was good at the start and occasional feedback, but they weren't really authentically involved because of time pressures. I kind of went ahead and did it, so if you know what I mean. So the lesson is that engagement must be authentic. One must plan well ahead, and that's part of the issue in terms of the timing that Jeannie was talking about. Different priorities, different calendars. And also it's important, we've had lots of wonderful debates about the interaction of clinicians and researchers in terms of getting new projects going, and to be time efficient, to not only go ahead and do something with clinicians who might not be as experienced at research as researchers, but if they are less experienced at research, to optimize methodological lessons as one is going along, as well as doing the project. So that is me. I'll pass it over now to Nadjib, who will talk about his lessons from a practice facilitation and research facilitation point of view. Thanks, Nadjib.
Thank you, Peter. So if you don't mind, I will do it in French, ça sera plus rapide. Donc, je vais essayer d'être très bref. Donc, ce sont juste quelques mots pour partager avec vous quelques réflexions de mon point de vue en tant que facilitateur de la recherche. Donc, pour schématiser rapidement, et tel que le montre l'illustration, mon rôle en tant que facilitateur consiste à essayer d'être le pont entre le milieu de la recherche et le milieu clinique, en aidant celui-ci à participer à des projets de recherche, puis idéalement concevoir ses propres projets de recherche. Donc pour ce qui est du projet de téléconsultation que Peter a dirigé, puis pour lequel j'étais facilitateur, et qui a impliqué les 4 autres appels, j'aimerais juste partager avec vous de manière non exhaustive quelques-unes de mes réflexions. En fait, le projet a renforcé l'idée que j'avais au préalable, c'est que le fait de collaborer avec les autres facilitateurs des autres appels, des autres PBRN, a fait en sorte que le recrutement des milieux cliniques qui ne font pas partie de notre réseau, le réseau McGill, a été beaucoup plus rapide. Donc, bien sûr, il y a certains paramètres qu'on ne contrôle pas forcément, pas entièrement en tout cas. Je pense particulièrement aux demandes d'éthique et demandes de convenance institutionnelle pour lesquelles le contact avec les comités, les institutions est beaucoup moins fréquent que les cliniques, pour nous les facilitateurs. Donc, mais là encore, ça aurait été beaucoup plus difficile et donc beaucoup moins rapide si je devais le faire contacter ces comités par moi-même. Donc, le rôle des facilitateurs dans cet aspect-là était d'une grande utilité, d'une grande aide aussi. Donc, dans une autre dimension beaucoup plus petite, mais non moins importante, les personnes qui ont porté le projet dans les milieux cliniques de McGill, qui ont participé au projet, et même celles, je dirais même que les autres cliniques qui font partie des autres réseaux PBRN, qui ont transmis, au fait, qui ont joué le rôle de transmetteurs, ils ont transmis à leurs collègues et font circuler l'information sur le projet. Et en quelque sorte, ils ont joué le rôle de facilitateur dans leur milieu, a été d'une grande aide et d'une grande valeur aussi. Donc, ces personnes clés ont non seulement été des portes d'entrée du projet vers le milieu, mais ont aussi facilité son exécution. Donc, cette collaboration avec les personnes clés dans les cliniques m'a permis de développer des relations avec d'autres personnes du staff que je ne connaissais pas avant. Et sans surprise, c'est donc beaucoup plus simple et beaucoup plus rapide lorsqu'une personne te présente aux membres de sa clinique que si on doit le faire soi-même. Donc, on a beaucoup plus confiance en une personne lorsque celle-ci nous est présentée ou référée par une personne qu'on connaît déjà. Donc, toutes ces relations de confiance rendent le terrain beaucoup plus fertile à de nouvelles collaborations dans le futur. Et c'est ça, on espère que ces collaborations seront beaucoup plus nombreuses. Donc, je tiens à remercier toutes les personnes qui m'ont aidé, à soutenu dans la facilitation dans ce projet. Et merci surtout, un grand merci à nos cliniques et à nos personnes clés dans ces milieux. C'est que sans elles, nous n'aurions pas pu, ça aurait été beaucoup plus difficile pour nous de faire le travail aussi rapidement et aussi bien. Donc, je passe la parole à Alayne.
You're on mute, Alayne.
Okay. Sorry for that. I will be speaking very briefly about a study we conducted on the issue of telemedicine, but focusing in particular on the patient perspective. And it is a nice complement to I think what Peter has just presented, but it provides a slightly different sort of perspective, which I think is valuable. And the study arose from a question that was posed by a family physician and who was a collaborator in the study, Isabelle Leblanc. Why aren't my usual socially vulnerable patients showing up in telemedicine visits? And I think very much more importantly, and what we'll be stressing here, what do we need to do to adapt telemedicine modalities to meet their needs to a greater extent, to increase access to this, I think, very important modality of care. So, so I'm going to very, very quickly give you some of the results from the patients themselves, and then Jeannie will follow up with, I think, a really important part of the study, which was the deliberative dialogue around solutions. And that was important so far as we went to clinicians, we talked about, and they came up with solutions. We also went to community and heard from them with respect to what they felt needed to be done and their response to the solutions and additional suggestions. And then I think Kimberly at the end will be reflecting on this whole process that of research that we undertook together and what was learned through that. All right. Okay, so the study itself was a qualitative study with great determination, despite many challenges, because this was the height of the first wave of the pandemic. We managed to get 29 members of high need households and speak to them over the telephone, which I think was a big issue in this research. We didn't have the same opportunity for trust building and familiarity that is so critical to qualitative research, but what wasn't possible in this context. So, you know, they did share, perhaps not as rich the data set that I would have loved, but we did derive a lot of insight nonetheless. So most of these, the large majority were clients of the Côte-des-Neiges food bank, nearby our department, and we recruited them through their regular sort of the regular sort of donations of food baskets that occurred at this food bank, but also through family physicians. We recruited some there as well and tried to get a sample as varied as possible in terms of gender and immigration status, age, and whether or not they had access to RAMQ card and a family physician. All, I should stress, they were all high patients or family members with health care needs. And we employed framework analysis. It's not terribly interesting for all of you. But our general findings, first of all, there was a general recognition that telemedicine is a useful thing, particularly during the height of the pandemic. There was a sense that risk could be minimized by not having to do in-person visits. The time savings, obviously, everybody experienced that. And I think there was a general sense that it was a fairly efficient way for taking care of minor problems, refills, follow-up visits, and some even mentioned for mental health care. But I think that was only a few respondents. But there were also there was a strong sense amongst respondents that telemedicine was particularly irritating. I mean, we all are experience irritants with in-person visits in terms of appointment getting and time waiting, etc. But this was particularly exacerbated with telemedicine. So challenges with appointment booking were one of the big ones. Difficulties getting through on the phone, multiple tries, a lot of difficulties with the RVSQ, especially for those who didn't have access to computers, and also very long wait times to appointments at that point. And then a lack of preparation as well on the part of the patient in terms of what they needed to come to the appointment with in terms of material, photographs, whatever that might be, not knowing that the appointment would actually be a telemedicine appointment. Some went to an in-person visit and returned back because it was telemedicine. missing the doctor's call, what you do, and this whole issue of the no caller ID and many people not answering those calls. Sorry, did I miss one here? Yeah, so the logistics of the encounters, we had appointment building, then we had a logistics of encounter. And here we had respondents talk about some of the anxieties around getting the call, being afraid of missing the call, and then having difficulty getting through again. Technology was also a big issue amongst our respondents, many of whom lacked the required equipment for obviously video calls. Some lacked the technical support, or even members and families who could support. Physically having to sit beside a landline in certain cases, and issues about privacy as well. Then there were quality of care concerns. Many shared that it was difficult for them to understand the clinicians in these encounters because of language issues, and the lack of nonverbal visual cues. The tendency also for these appointments to be focused on a single problem when multiple problems might be experienced at one time. And then, of course, this issue of the lack of physical or visual examination. And quite a number of respondents expressed that they didn't really feel like they had been seen by a clinician, which is obviously a problem. Another issue had to do with the fact that a trusting relationship with clinician may not, have existed before the call. Many of these calls are being fielded by residents, and I think that has been rectified subsequently. But in cases where there are problematic relationships with primary care providers, those issues were exacerbated in the context of these telemedicine encounters, and obviously the lack of comfort on the part of respondents if they didn't know the clinician in before the call. So both undermine trust in the quality of care. So just to say that we're at a pivot point in terms of telemedicine, and the importance of trying to improve this modality of care and the patient experience with it in particular. A lot of the issues that were raised are relevant to everyone, not just those patients who are high need. But that being said, it is really important that special consideration be given to individuals with certain vulnerabilities, such as limited language proficiency, working schedules which are inflexible, so it makes it difficult to receive a call, issues around with respect to technological sort of capacity, ability to receive a video call, this issue also of privacy, which Peter mentioned, and I don't know that last point, Jeannie, so you may have to, I think it's your time to chime in. But what was that last point? Reason for visit masks? Oh, I see.
It's just that they had made an appointment to talk about a stomach ache, but in fact, they really wanted to talk about a mental health problem. So there wasn't a good way to transition between that. So.
Okay, so I'm going to turn it over to you now, Jeannie, and tell me when you want me to advance the slides.
Okay, so you're advancing slides. That's great. So we'll just go on to the next one because we want to really move now about what we did to identify solutions in the middle of this. I want to start just very briefly talking about our conceptual model, which is the next slide. And please don't be terrified by this. It's kind of busy, but I just wanted to say that we used Levesque et al.'s patient-centered accessibility framework. We thought it was very relevant because it actually talks about all of the way that provider characteristics interact with population characteristics along different stages of the care process. And we made some adaptations to the model, but just to say that there were obviously things that needed to be changed from the way that healthcare access is generally conceived. I just want to say that we found that there was a lot of information, and the whole step about deciding whether you're going to get care or not in the pandemic context and in the telemedicine context was a really big consideration. And then instead of the issues that would be around traveling to the clinic, the logistics of getting care were all about the technology that was available. We also want to say that we actually found that, and it was the last point that was made by Alayne about the quality of the encounter. If it was a problematic encounter, we actually found that people were less likely to follow through afterwards, or they just were not engaged in following through. So that was the real issue. And so this was actually helpful for us to sort of find sense and really focus on the areas of appointment keeping and and the quality of the clinical encounter as the areas that really needed to be changed. So we're going to skip. What we did was, we'll go to the next one. So what we did was that we actually engaged in some solution-oriented deliberations with clinics, and then again back with the community around the two particular issues around appointment keeping and quality of the clinical encounter. We had one question was more about what the team as a whole could do to improve appointment booking and just the logistics of telemedicine clinical encounters. And this deliberation was predominantly by administrative staff in the clinics and the front office staff. And then generalist clinicians and like nurses and family physicians were actually deliberating about what the team could do differently to enhance the quality of telemedicine, to give patients that confidence that they had been seen and can actually care for themselves in the future. So the next one, what we did, we actually, in the process of deliberation, so a deliberation is like a facilitated, curated kind of conversation that deliberates evidence and then comes up with kind of collective decisions that can be acted on. So we had these encounters in which we did a quick overview of the findings. Then we broke into small groups based on roles. And within the small groups, people reflected on what possible solutions could be. They then prioritized them. They identified things that might be relevant to other groups. Then everybody comes back to the main group. We voted, and then we wrapped up. We were actually able to do this usually in about an hour and 25 minutes, which is pretty remarkable. We got some very valuable information. And we actually did this process in 3 clinics. Just the next slide, maybe. We conducted separate deliberative dialogues in 3 of our practice clinics. We then synthesized what their top solutions were, and we actually, on the recommendation of the clinicians, went back to members of the community to say, how did high need people who represent high need populations respond to these solutions? And that's what we want to present to you right now.
Jeannie, before you move forward, just to know that there are 15 minutes left to the presentation.
Thank you. I'll try to do this quickly. One of the first ones was to just really provide much more information to patients so that they're better prepared for the telemedicine encounter. And there was some information that was proposed by clinics, and maybe you can look at this afterwards, but it was very much in line with, our findings, and then just the fact that what some of the things that need to be done in a medical encounter. We independently asked our community members in their deliberative dialogues what they thought, and they all agreed this was important, but they also thought it was important to address some of the myths and rumors around telemedicine and just describe briefly what happened, and maybe just have a little bit more frequently asked questions. So it seemed to be, this was very well received, that there would be some kind of brochure or something that would explain a telemedicine visit. The next solution actually focused on the idea was that administrative staff get much more involved in asking questions to determine right from the outset if telemedicine is an appropriate type of visit. And so the clinics proposed that they ask about what is the patient's experience with telemedicine? Do they already know how to do it? What is the reason for their appointment? whether the patient knows the physician already or not, and what their kind of technology capacity was, and whether they had a private space for the appointment. These questions were actually very well received by the members of the community. The only thing that they said was they would sort of, if people feel reticent about providing a reason for the visit, that maybe they could provide some general categories that they could respond to, and just so that they would know why they were asking. They also thought it was really important to remind the patient that they actually had the right to ask for an inpatient visit. And we were really surprised in the technology. They said, ask if the patient even has a phone, because a lot of their clients actually will have a central phone where they will go to a community organization, or there's neighbors who share a phone. And so they don't always have the capacity to wait for a call. That was sort of surprising. The third solution that was suggested by the clinics was to actually promote and increase the use of patient portals for transmitting information and just for communicating with patients. The community views on this were very interesting, because they said, when they suggested how they could be communicated with completely independently, they almost had no digital mechanisms like, portals or even email or texting that they wanted. They really wanted like a physical brochure that they could pick up from a trusted source that they go to a lot. Or they also thought that if this information could be on the websites of their community organizations or the clinics or hospitals, but it was actually quite a disconnect between the way they got information. And the last solution is the clinicians said that in order to make that communication clear, they actually proposed things that should be addressed at every level. So just at the beginning of the visit, making sure that they reinforce what this visit will be like, what to expect. And then before closure, this was probably one of the most important things, was to actually engage in some kind of teach back sessions with the patients, to hear from the patients what they understood, and then to also repeat to the patients what the physician understood before closing. And then just to really take the time at the end to say, is there anything else and that we can address at the next visit, and determine whether it's in person or not. So these were the solutions that came out. And the next one is just, we wanted to ask Kimberly if you would reflect a little bit on some of the clinician perspectives on this collaboration.
So these perspectives are shared with myself and Isabelle Leblanc and Mylène Arsenault, who unfortunately couldn't be here today. So we thought about what did we gain through this collaboration, and I think in summary, it was a learning experience for all of us and mutually beneficial. On the left here, you'll see the researchers what they gained from the experience, and on the right is our clinicians' perspective. So maybe I'll start with the researchers' experience. So having the clinician presence in the research meetings often allowed to keep on track and to really focus back onto clinical realities. We did learn, I think all of us learned that rapid research is maybe not as rapid as the changing clinical context, but at the same time, we did manage to come up with some really useful findings in terms of how to go forward with telemedicine in the future, even though now we've kind of rotated back to seeing a lot of our patients in person. Sorry? Okay, and also so for us as clinicians, I think it's very useful to keep focused on questions that are pertinent to our clinical settings, which I think was done quite well during this research project. We as clinicians developed a real respect for researchers and all of the steps that need to go through to actually get a research project up and running, and this one was quite quick, but at the same time we were still working on it for a good 10 months. So so kudos to all you researchers out there. We can maybe move on to the next slide, I think. So inserts into telemedicine in general. So the pandemic really did offer us a new type of service delivery. As Peter mentioned, in Quebec, telemedicine wasn't widely used before the pandemic, and then all of a sudden we pivoted to using almost exclusively telemedicine during the first wave. So I think it did open our eyes to the people, to the ones of us who are maybe a bit more reluctant to start using it, and it is a modality that's here to stay. So. However, when using telemedicine, I think all of us are quite aware that communication is always important in medicine and in patient interactions. But in telemedicine, it's even more important because, like we said, we don't have the same physical contact. We don't if we're doing it by phone, we're not seeing the patient. So it really is important to make sure that the communication is clear and consistent. The point raised about the person's sense of having a real medical appointment and feeling touched was I think especially important for us to realize, and also us as doctors as well. Sometimes we got the impression that we were doing an appointment and the person wasn't really considering it to be a real medical appointment, because at the end of the encounter they'd say, okay, so when can I see you? So I think that that idea of ensuring in-person care when important is quite relevant, and it really does take the whole clinic for telemedicine to work. So like mentioned, the frontline staff are the first line of who contacts the patient, who receives the call, who books the appointment. And it's important for those frontline staff to be trained on how to coach patients and how to advise them of how the encounter will take place, how to get them all set up in terms of their technology, because it can be quite time consuming if, as a clinician, you're doing all of that when you're on the phone with the person. Equity was one of the reasons why this project got started in the first place, because we weren't seeing a lot of our vulnerable patients. So equity needs to be an important principle to guide us in how we're using this technology. So constantly considering how these new changes in service delivery are affecting our vulnerable patients is very important. And like Jeannie mentioned, whenever we're thinking of doing a change and improving our systems, going back to our patients, our patient partners, to see, is this a change that will in fact help ensure access and ensure improved service. And finally, so telemedicine is a new technology, is an important technology, and it can be used successfully, but we do need to take into consideration the types of problems that people are consulting for, and also the types of patients that we have in front of us, including other different social determinants of health. Thank you.
All right, thank you to all of the presenters for this amazing presentation. We have about 5 minutes for questions, so maybe we'll just go through 2 or 3 questions. I see that Vladimir did post a question, but Peter had responded, so maybe we'll skip directly to Tibor's question, which is, telemedicine has been around for quite a while, especially offered by private entities. He is wondering if conventional primary care providers who had to move to telemedicine quickly can learn from the vast experiences the sector has gained. In other words, are there potential interaction points, such as mutual learning opportunities between private and public sectors and the PBRN? Would any of you like to tackle that question?
I mean, not necessarily more than what I wrote, but I think, yeah, I appreciate it, Tibor. I think that's a great point. Yeah, thank you. If there's a lot that's been done in the private sector, a lot of lessons to be learned. I think, especially from a logistical and a technical point of view, how they've kind of overcome it. I'd be interested to hear more, like, and maybe like offline, you could point to some sources if you know it, because I wonder whether the private sector, has confronted some of the issues of kind of ownership of a health system and feeling like you know, you own the whole system and it belongs to you, you know, in terms of a public system, you know, those kind of, you know, political things. And I'm wondering whether, you know, some of the vulnerability issues, you know, might not be as covered in the private sector, given that presumably people, you know, are well enough off to be able to afford it. But maybe it does. Maybe the scale of activity, I mean, the private sector still covers issues of, you know, marginalisation and vulnerability. But yeah, I appreciate that. Thank you for the tip.
Yeah, would love to have a chat at some point more in detail. Obviously, we don't have time, because I know a few individuals who work in telemedicine, nurses and doctors even, and I think the patient populations are overlapping, and it's kind of out of the box, you know. And I think we may start thinking, because we want to do the same and improving patient health. So.
Yeah, and also there's an uptake issue that, you know, we could learn a lot about, like a knowledge translation issue. I mean, it's not done. There's not obviously not the incentive to invest in strong internet in the community. You know, to see in 2021 that, you know, having good strong internet and good technical facilities is actually almost a basic. I don't know, dare I say a basic need? It's not a basic need, but it's not as far off it as it was like 20 years ago, you know, and also, you know, the uptake of clinics. I mean, maybe there needs to be stronger drivers for integrated EMRs and to overcome the issues of, you know, privacy or whatever it is that seem to impede it, especially in this province. So thanks for opening that up, Tibor.
Thank you, Peter, and thank you, Tibor, for the question. Dr. Dipokamandi, would you like to speak?
Yeah, well, first, thank you for this great presentation and congratulations for your work. I would just say, though, that to Tibor, I don't think that clientele is overlapping that much. And maybe Kimberly, you can say that. I mean, they're overlapping in this higher little part of society, but most of the general population cannot afford private care. And this is actually in this population that we encounter the most difficulty. Those who are connecting through their work through Zoom are doing well, but and just as curious, Kimberly, what will be your practice? Because I know that for us at the HIV clinic at the MUHC, we were all enthusiastic about this. Then we realized that phone was often more appreciated by our clientele. And then everyone wants to go back to in person, because in the end, they prefer to see us. Many of our patients had so many difficulties with that. So I don't know what's your, like, we're going back to in person in the end, and just few. So what's your feeling?
I share your reflections. I think so. The thing about the private sector as well to consider is that they're not responsible for continuity of care. So for punctual, like for very brief encounters, you know, that can be easily done over the phone. I think the pandemic showed us and showed us that the public sector can also do well to respond quite well for very punctual concerns. You know, something that could be addressed easily. But I agree that for the vulnerable patients, it is still very difficult for them to access, and our patients as well really expressed wanting to come back in person, and as providers we wanted them to come back. So actually, interestingly, when we were doing the deliberative dialogue here at ParkX, it was the week that we had decided that, you know, we're really coming back almost like before. We have been seeing patients throughout the pandemic because we have particularly vulnerable patients, but since this summer we've been, I would say, you know, is at least 70% in person, and that's the providers and the patients, I think, have expressed that desire.
Yeah, I just wanted to add, to type in the chat, but I think we should have a discussion if this is really all the privileged individuals who do private healthcare. I think a lot of issues are access issues, and they often people are forced to seek private healthcare, which is very expensive, very discriminatory in the system. And I think that's why there's surely also vulnerable populations that might be relevant in the private sector.
If I could just speak to that, one of the things that came out in our studies, that one of the reasons we actually had to go and recruit from patients seen by family physicians was because when we talked to our high need patients, there were so many of them who just had trouble accessing Pointe à la Ligne. It was like a lot of people, we were surprised about how many people didn't have RAMQ cards, or for whatever reason just couldn't even get into the system. So those are not the people who are being seen by telemedicine, because we were interested in the primary care clinics, but definitely access is an issue. I'm not sure that the private sector is a solution, but it is often the only solution people have.
Thank you all for your comments and questions. It is past 1:30, so to be mindful of everybody's time, we'll end there. I'll just like to let you all know when the next presentation or seminar will be, which is November 5th at 12:30 to 1:30. It will actually be led by the Family Medicine Education Research Group, and it will be on using interpretive description as an approach to qualitative medical educational research. So I posted the link in the chat, so feel free or keep an eye out for the registration email to attend that one as well. So thank you to all the speakers, and thank you to all the attendees for participating in this seminar. See you all on November 5th.
Thank you so much.